Hello, everyone. I'm Talaya Dendy, and you're listening to Navigating Cancer Together. It is the show that has something for everyone facing cancer. Why? Because everyone is different with different needs, beliefs, and perspectives. Thank you for joining us for this episode. I encourage you to open your minds and your hearts. Navigating Cancer Together is everywhere. Please make sure to subscribe and follow the show to stay updated on our latest episodes. You can listen on Spotify, Apple Podcasts, YouTube, or your preferred podcast app or platform. May is a very special month. Mother's Day, Memorial Day, we have all these things coming up in May. And of course, we have all of our cancer awareness days in May. So we have some special days that we're going to be touching on. We have two very special guests here with us today. Get ready to meet a true game changer, maybe for the first time or the second time if you are familiar with the show. He is a game changer in cancer care. Returning to the show is the incredible experienced Dr. Thomas Eanelli. He is a radiation oncologist hailing all the way from New York with decades under his belt. Dr. Eanelli's compassionate approach isn't just care. It is the gold standard. But here's where it gets really interesting. You might just catch Dr. Eanelli in a sports jersey. Find out how his unique touch fosters a sense of teamwork, keeps vital information flowing, and makes world-class oncology care feel a whole lot more approachable. Angel Santana joins us as well. He is the co-host of the CROC Podcast, and he is Dr. E's right-hand man. Angel also hosts his own podcast called Have Faith, Let It Begin, a show designed for the daily commuter with motivational topics, inspirational stories, and personal testimonies set out to change the world. I am thrilled to welcome back Dr. E and Angel. Welcome back to Navigating Cancer Together.
Oh, Talaya, it's such a pleasure to be here. You are indeed one of our absolute inspirations. When I found you that fateful day, looking at the back of a journal and seeing your picture and seeing the words cancer doula and just kind of leafing through the article in your interview and then getting to meet you, sending you an email and the whole thing. And oh my God, your story is just incredible. And it's almost as if we have a thing. We have such a connection because I think we're both trying to do the same thing from different ends of the spectrum. Angel, would you agree?
Absolutely. It's like being at the World Series every single day. But, I feel like we've locked down the almost half of the week. You've got, Navigating Cancer, new episodes every Wednesday. You've got the CROC Podcast on Sunday. You got Have Faith, Let It Begin. There's no more days left. You're just going to have to, and fulfill and just have a good time.
Yeah, listen, everybody, cancel all of your other subscriptions. You're done. If you're having a bad day and you need to be uplifted spiritually, Have Faith, Let It Begin. If you need any sort of advice on navigating your survivorship, Talaya Dendy. If you need some knucklehead advice from some crazy doctor in New York, I'm your guy. So we got everything covered. You don't need to listen to Oprah. You don't have to listen to Michael Jordan. You don't have to listen to anybody. All you do is come to one of these three podcasts.
What Dr. E said, what Dr. E said. I second that. And you know what? We got you covered. So let's dive in, gentlemen. Dr. E and Angel, for people who may not have listened to the other episodes that you have been on the show, please let the new people know who you are and what's something interesting or unique about yourself that might surprise them.
Thank you, Talaya. That's a great question. So the Citizens Reunited to Overcome Cancer organization is a grassroots cancer support group that started over 25 years ago. I think this is our 26th year. And it started very interestingly, not a word, but we make them up here. I was at a Relay for Life, and it was back in the early 1990s. And to see the cancer survivors walk around and do their laps, it was just very incredible. And then I kept on thinking about it, and I would go to work and I would go home, and I thought, there's not enough. It's not enough for this, for this group of survivors, this group of thrivers who have to deal with the big C, who have to deal with that four-letter word, with an illness that is just unfair, unrelenting, nefarious, notorious, just such a terrible disease. And then the treatments for the diseases are equally as, difficult and trying and substantial at a huge cost to the survivor thrivers' quality of life. And the fear, just that fear. And it just kind of came to me sitting in my waiting room, talking to patients while they were waiting for their treatments, seeing that energy, and then trying to figure out a way of curating that juice, that strong, powerful juice that was happening between survivors, and just getting them together was what the first incarnation of CROC was. Now, 26 years later, we've tried to reach more people through our podcast. The podcast pretty much symbolizes or emblazons our four foundational pillars. And these are the things that we work both in the clinic on a day-to-day basis, as well as on the internet waves here, trying to tell people that they deserve to have accessibility. That means they should be able to have access to their healthcare providers. They need informality, so they can feel that they could be themselves and they could develop a trusting and friendship-based rather than a physician-based dyad where the physician's all the way up here and the patient's all the way down here. We try to bring those two platforms, those two situations, those two positions, try to bring them as equal. And that's especially true in this day and age of now shared decision-making. The other things that we do is we need information. Patients, survivor thrivers need to have access to an educational platform. There's just so much exciting things going on out there. You know them, Talaya. Immunotherapy, targeted therapy, genomes, genomics, molecular evaluation of tissue. It's just everything is changing at such a rapid rate. We're going to be talking about some of those things today, actually. And of course, just supporting the survivor thriver, just making them feel loved, just creating a relationship rather than this professional, standoffish, completely detached dyad. And that's what our goal is. Angel, I want you to add to that and maybe help people be able to reach us.
Again, thank you for having us. One of the great things about Citizens Reunited to Overcome Cancer, which we call the CROC Podcast, is we want everyone to forget about everything about their cancer. I want you to have the clean slate, as Dr. E so eloquently puts it. CROC is not so much a thing, but rather a movement for survivors. And as he stated in his big mission statement, it's to gather and learn and to be nourished and to connect for a brief moment and forget about the future because, we have to focus on the now. Being a producer and co-host, we have the luxury of being on the air now for 5 years. And in the 5 years that we've grown, me being, of course, an outsider and not a cancer patient, but listening to it for more of a audience perspective and giving a little bit more spiritual guided feedback at times based off of my own podcast. It's another way for us to just not so much as reinvent the wheel, creating the wheel and just allowing that wheel to spin in that direction so that we can create this path, this amazing path of righteousness to all those that are just blessed to listen to your show, our show. And we're like you, we can be listened to on every platform. And we invite everyone to take a look. In addition to listening to Navigating Cancer Together, we're available at crocvip.com. And we'd love to have you come on and listen to us as well.
Wonderful. Please listen to the CROC Podcast, and you can find it at crocvip.com. That is spelled CROCVIP.com. And take a listen. You'll hear my story. You'll hear the stories of so many others. And there are a lot of life-changing perspectives on the CROC Podcast. So make sure that you take a listen. You will not be disappointed. But don't only listen, share it. Tell others about it. All right, gentlemen, thank you so much for updating the listeners on who you are.
I have to tell you, I want to ask you both. It is hard. The first time I got in front of a microphone, I was very stiff. And when I look back at like those first podcasts, Angel sometimes makes me listen to them. Everyone thinks that just, having a podcast is the easiest thing in the world. Just trying to talk in a microphone, trying to put together relevant content every week, trying to find guests of the caliber of you, Talaya. It's hard work. It is difficult. And it's hard to also create people to listen because there's so much out there. When we started CROC, it was tumbleweeds. And that's exactly why we started CROC, because there were no support organizations in the Hudson Valley. We had the American Cancer Society, and that's it. So to be honest with you, I've kind of looked at the last 5 years as a science project, just as an experiment. Angel and I, the mad scientists behind that curtain, the Wizard of Oz, just trying to devise a way that we could come up with a content that we could be be proud of, present it in a professional way, and also motivate and inspire people the same as you do on a daily basis, Talaya. Angel, would you agree with that?
Absolutely. Hey, listen, anytime you get a microphone and you can have the nicest backdrop, you can have the coolest intro, but if you cannot identify who your audience is, and you both hit this right on the head, it's listening to your audience and understanding what your content is. We as podcasters know it changes, it can evolve, but it's what you listen with your audience and what you put out. You can't be somebody other than yourselves. Talaya, that's why I think we love having you on our show and we love coming on yours, because you ooze that amazing love and passion that you put out, and the microphone isn't doing the work for you, it's your heart. And I think that is key. As for Dr. E, the same thing. It was a work in progress, but he found his niche and he just became himself. And the microphone is his patient, and your audience is your microphone. That's the key.
You know, it was very hard to switch directions from a monthly educational social gathering with 200 survivor thrivers crowding into my brother-in-law's restaurant and eating pizza and listening to music and listening to me give a lecture about a certain subject, and everybody just having the greatest time ever and hugging and crying and laughing and, repeat, every month. And now having the opportunity to reach out to people in other countries, people in our own country in different states.
Just to kind of piggyback off of some of the things that you and Angel have shared about podcasting, and it is a job. And it is a job that you have to enjoy because there is no instant gratification. It takes years to build up your following. And I think more people really need to understand that for me and you as well, not to put words in your mouth, but this is not a passing or fleeting hobby. This is a mission. This is something that is very near and dear to my heart. And I'm in it for the long haul. So I just really want people to understand all that goes into creating a podcast. It is not just getting on a mic. It is finding people that you connect with, helping to share very important stories, and then also making sure that you are reaching people right where they are. Those are some of the things that I think are really important about podcasting. And it really is about doing things together. We can all do our separate things, but when we come together as a collective, that's how we have the greatest impact. So for anyone out there listening, just know that for myself and the parties here today, this is not about competition. This is about coming together, trying to figure out how we can reach more people and share hope, encouragement, and awareness with more people who are out there. So as Angel said at the top of the show, listen to both shows, share both shows, and engage with us. We want to hear from you. We want to talk to you. We want to know who you are, because we are doing this to talk with you, to make that connection with you, and truly let you know that you're not alone. You are definitely not alone. So thank you, gentlemen, for your insights. Now we're going to transition. This episode will be airing in May. There are 3 cancer awareness days that are taking place in May. The first one is melanoma, skin cancer is the second one, and then bladder cancer. Dr. E, have you supported patients that have had either one of these cancers? And what was their initial reaction to the diagnosis?
Yeah, thank you very much. I'm really excited about talking about all 3 of these subjects. So let's start with bladder cancer. So this is really, really important. Bladder cancer is silent except for one thing. You can't get away from the fact that at some point a bladder cancer will bleed. So you will not feel it. You will feel fantastic. You could run a marathon and you can go to the bathroom, go to the urinal, go to the toilet, whatever. If you see any blood in your urine ever, I know you're going to say it's a UTI. I know you're going to say that you probably just pinched something or you've strained a muscle or whatever. I need you guys to get to the urologist as soon as possible. Painless hematuria is the sine qua non. It is the absolute number one presenting symptom for bladder cancer. And the great news is that if you seek help immediately, most likely the bladder cancer will be diagnosed not only at an early stage, but at at a stage 0, which means that that bladder cancer has not invaded into the muscle. So the bladder, if you think about it, we all have a million jokes to talk about bladder. We can talk about our small bladders, our big bladders, and how much we urinate, how little we urinate. Women are like camels. I can go on forever about all of these references to our bladder, but I will say this. The bladder is just a muscular sac. And this muscular sac really only has a function to act as a reservoir as the kidneys filter the blood, take the waste, store it in the bladder, and then the bladder contracts, and that's how we urinate. Anytime that you see blood in your urine, it'll be painless unless you've waited too long. You have to go to the urologist. When you go to the urologist, they're going to do a procedure called the cystoscopy. Anytime I say scope, it means that we use a fiber optic apparatus to be putting in. Sometimes we put it through the nose to look at the larynx. Sometimes we put it in the rectum or into the bowel to do a colonoscopy. Sometimes we bring it down the esophagus. That's an upper endoscopy, but a cystoscopy is through the urethra. So in men, it's going to sound terrible, but the cystoscope goes through the penis, into the meatus, and then into the urethra, and then finally into the bladder. That urologist will be able to see all of the walls of the bladder. So there'll be the anterior wall, the posterior wall, the lateral walls, the medial walls. They'll be able to look at the trigones, which are the small openings where the ureters from the kidneys join in, and they'll be able to see the source of the bleeding. They'll do what's called a biopsy of that lesion, and then the pathologist will tell us whether or not that tumor is going to be infiltrating. First of all, if it's a tumor at all, because the majority of these abnormalities usually are not cancerous. If it is cancerous, if it has invaded into the muscle, so the inner layer is called the mucosa, and the middle layer is called the muscular layer. If it gets into the muscle, then we're going to talk a little more extensively about that. So let's take and presume that a patient has a non-invasive bladder cancer. So you have a lot of hope. You can absolutely live your life normally. You're going to most likely get infusions of medication actually into your bladder. So a catheter will be placed. You'll go to the infusion center. The bag will be filled. This bag will blow into your bladder and fill it with medicine that will hopefully kill those abnormal cells. If you have a more extensive bladder cancer that actually invades into the muscle and you're a healthy individual, you will most likely be a candidate for what's called a cystectomy. The cystectomy is the surgical removal of the bladder. So you're going to say, Dr. E, how can I live my life without a bladder? Well, again, fear not. Your urological surgeon, your urologic oncologist is very skilled. They have had the tools, but their techniques are improving. They actually create what's called a neobladder. So what happens is they'll take out the bladder and they'll create a neobladder. It won't be the same, but at least you'll have a mechanism in order to stay as normal as possible. So that's called a cystectomy. Post-operatively or even pre-operatively, sometimes chemotherapy is used. That is the drugs, the chemotherapy, the anti-cancer drugs, which go into the vein where you go to the infusion center and you sit in that chair and you get pre-medicated and you get all these infusions. And that's another way of managing a bladder cancer. And of course, what I do is the radiation part. I wanted to spend a few minutes, since that's what I do, to also talk to you guys a little bit about the concept of less is more. So when I first started, one of the cool things about being around the block for 3.5 decades is that you've seen a lot of things, and you've seen the old way, you've seen the middle way, and now you see the new way. And usually the old way is a bad way. And that's very true in medicine, as I'm sure it is in anything. And the bad way was to do too extensive of a surgery. We used to call it the Hallstedian approach, which means basically take everything out and exenterate and just clean out the whole pelvis. And you might cure the cancer, or you might not even cure the cancer, but you leave the patient just a shell of a person. The survivor's life after that, the quality is very, very terrible. So now with all these new surgical techniques and all of these new mechanisms, surgery is a viable, and I'm going to use the word gold standard. It is the gold standard treatment for bladder cancer that's muscle invasive. Now, I use that word gold standard. What if you're an elderly patient? What if you're not an elderly patient, but you have a lot of comorbidities? That's a fancy word that doctors use that tell them that patients have a lot of other medical conditions. So you might have a really bad heart or really brittle diabetes or really bad vascular disease, multiple sclerosis, whatever. And you may not be a candidate to have the bladder taken out surgically. And that's where the medical oncologist and the radiation oncologist come in. Although it is the second line treatment for bladder cancer, it is oftentimes very successful. And I have more than a handful of survivor thrivers that I follow on a daily basis. I want to say in the dozens that we've treated for bladder cancer without surgery and have had a cure and have allowed our patients to save their bladder. So I wanted to make sure that I gave you guys that hope. So just to circle around and just recapitulate bladder cancer, since it's Bladder Cancer Awareness Month, painless hematuria, blood in your urine, get to the urologist. The urologist will then do a cystoscopy and tell you what's going on. If you have non-invasive bladder cancer, you're going to have what's called infusional or bladder treatment directly into the bladder with medication. If it's muscle invasive and you can have the surgery, you'll have the surgery with or without other treatments. If you can't have surgery, radiation therapy and chemotherapy, and fear not, again, I use the same expression, you're going to do just fine. I promise.
Dr. E, speaking from an emotional aspect, what is some advice that you have for the person diagnosed with bladder cancer and their loved ones? That is a huge one. It's not one that you hear about very often. And so there could be that additional element of fear and uncertainty because it's not something that a lot of people talk about, like breast cancer. What advice, coming from a doctor's perspective, would you give someone about taking care of their whole selves, their emotional selves, when they get this diagnosis?
You know, Talaya, that's a great question. And I really find a commonality, meaning that I know it's really important to highlight cancers. You know, each cancer will have a month basically for awareness and for educational purposes. But there is something common between all survivors, and it is that common thread of fear. And I think that what I would tell a patient is to find a practitioner that they feel they could connect with. To have a practitioner or a group of doctors and nurses and teams and cancer centers that have an attitude where the patient comes first, to have a safe place where they could be fearful and be uplifted. I have had so many patients come into our cancer center as afraid as a person could be and leave the center laughing and joking and slapping each other on the backs and just knowing that they're going to be okay. And I think that's my advice, is to make sure you could find that place. If there's a place you don't feel comfortable, a place you don't feel you can express yourself, a place where you feel you're getting the bum's rush, if there's a place where, you know, the doctors, you can't get in touch with them, you know, you have a problem and you call the answering service and it takes 8 hours or a day for someone to get back to you, you know, that's not the place you want to be. You want to make sure you can trust. You need to develop a trusting bond between your healthcare team and yourself, and especially for bladder cancer. In genitourinary cancer, you know, prostate cancer gets all the, you know, it's almost as if that's the Frank Sinatra, and there's the Bowery bum, which is bladder cancer. The other thing is bladder cancer is very scary because a life without a bladder is a lot more horrifying than a life without a prostate gland. I also have to lay it young people, healthy people that we take care of for bladder cancer with chemotherapy and radiation, because they just absolutely would rather die than have a life without a bladder. And when we talk about things like, you know, colorectal cancer, and we talk about bladder cancer, we talk about the evil, you know, the unspeakable word ostomy. Right. So even though we were creating a new bladder for you, it's going to not exit through the urethra anymore. It's going to be exiting through an ostomy, or an opening that's going to be on your abdominal wall into a bag, or if sometimes they can create a neobladder where you don't need that. You could just kind of, you know, discharge your urine at will or as needed. So that's a very harrowing thought, is to live your life to be mutilated, you know, to feel mutilated. But again, I see a commonality between that and everything else as well. I mean, women who have had mastectomies, you know, men who have had prostatectomies. I mean, these are very disfiguring surgeries. And I think for bladder cancer, to your point, I think that's what you were probably heading toward.
Yes, there's not enough resources, I think, for bladder cancer. There's all these organizations and support systems and things for breast cancer. And I'm hearing more people being diagnosed with bladder cancer. And to your point, even younger people. And so I think it's so important that you are sharing this information because we have to make sure that that awareness is there. And thank you so much for going into detail about bladder cancer because there's not a lot of information. There's not a lot of resources. Now, Dr. E, before you really dive into melanoma and skin cancer, please tell the difference between the two because a
Of
lot of
course.
times they're closely related, but there's a difference.
Yes. So it's kind of funny. We look at skin cancer as skin cancer that is either melanoma skin cancer or skin cancer that is non-melanoma skin cancer. So it's almost as if, close to your heart, Hodgkin's disease and non-Hodgkin's lymphoma. So that's the kind of way we break things up. Melanoma is definitely the desperado. It is a very, very feared cancer. It is not always, but usually pigmented. It's usually comes from what's called the melanocyte, which gives us the coloring. Each of us have different coloring. I have a certain color. Talaya, you have a certain color. Angel has a certain color. That's from our melanocytes. And these melanocytes can sometimes mutate and become problems. And I think that the melanoma is such a diverse disease. There's so many ways that a melanoma can be. So I've always noticed this in my career. I have seen melanomas actually devastate a person's body within 2 months. And I have seen people come in with extraordinarily extensive melanomas be cured of their melanoma. So I really view melanoma as not just one disease, but different sort of almost like a kaleidoscope where each of your melanomas are going to act differently. And we have the capability now of being able to molecularly blueprint these melanomas to have the doctors find these little Achilles heels. They might have this little mutation, the imperfection, like in Star Wars, there was that imperfection in that big, Death Cruiser or whatever that Death Star was. And they just had to find that Achilles heel and then attack it. And I actually just saw a woman this week who up until, maybe a month ago or maybe 2 months ago was traveling, was hiking, was doing amazingly great stuff. And now she came in to see me in a wheelchair. She has melanoma all throughout her body. However, she does have a melanoma that has a mutation. So I feel that this patient has a very strong chance of doing well. So if you do happen to have one of the more aggressive melanomas that have spread to the lymph nodes or have spread to the organs, spread to the brain, it's serious. I'm not going to lie to you, but at the same time, I want you to find a center that specializes in melanoma.
Dr. E, where are those centers? Are there any that you can mention or places where people can look?
Yeah, of course. Well, I'm in New York State, right? So there's a melanoma center at NYU. There's a melanoma center over at Memorial Sloan Kettering. I would have to think that in Rochester, Minnesota, they probably have a melanoma center at the Mayo Clinic. They might even have one at University of Minnesota. Unfortunately, everyone is going to have to do a little bit of digging and find, and we would be more than happy to help direct you if you give us any emails. Angel will tell you how to get in touch with us. If you happen to have a melanoma, tell us where you live and we'll find your center of excellence. We will help you with that. So it's just important for you to do that. So the centers of excellence for the people who live in the more rural areas that you don't have access to these centers of excellence. I will say that coronavirus destroyed our world except for one thing, the televisit. And we can also assist you in finding a center of excellence that will speak to you on a phone or on a computer to help you or help direct you or help direct your local cancer community cancer center and help you or look for clinical trials. I know actually some of the big centers that I refer to even have residences where you can actually travel, and sometimes they give you a grant to actually come to see them and they'll put you up and they'll try to help you. So fear not, even if you're a farmer in, the middle of nowhere in Nebraska and you're growing corn and you're called a corn husker, I'm sure we could find a place for you. If you're in a big metropolitan area like myself in Talaya, maybe a little easier, but certainly we can find that for you.
Thank you so much, Dr. E. The other thing I want to talk about is spring is upon us, and people are going to be spending more time out in the sun in the coming months. What are some things that people should look for in terms of skin cancer? Is it just a mole that looks funny or maybe painful? What are some signs and things that they should look for? And what role does a dermatologist play in all of this?
Oh my God. It's almost as if like we work together in cahoots to come up with these questions. So let's start with, I'm going to start with your last point first, because
Okay.
that's the most important.
Okay.
So everybody needs a dermatologist. All right. So absolutely. So now listen, everybody knows what they look like naked, and usually it's not pretty. I'll say, especially in Angel's case. No, I'm just kidding. And I know that holds you back from going to see a doctor that's going to not only, like, we've reached a point, sadly, with technology that doctors seldom touch patients anymore and seldom examine patients the way we were taught. But a skin doctor, if you're not naked in front of a skin doctor, then they're not a good skin doctor. You have to have a full body evaluation. You have to have all of those areas, all of those folds, all of those peaks and valleys looked at with a magnifying glass. And we have thousands and thousands and thousands of discolorations on our body. And the watchful and expert eye of a good dermatologist will be able to see all of these dark spots. I've gone to a dermatologist convinced that I had melanoma, and they would laugh at me and say, no, look at it, it's round. It's not spiculated. Look at the color. It's very consistent. There's no differences in the textures. And they're able to do that just by looking and seeing and evaluating. So you need to get naked with your dermatologist. There is no negotiation, and you should be seeing your dermatologist at least once a year. Guarantee you should do that, especially for melanoma. To your other points, I kind of hit on them, touched on them. The color, sometimes melanomas could turn purple. Again, you want to see color that might be brown and scary, but if it's brown and consistent, not as scary. You want to see round, you want to see small, you don't want to see little finger fronds, or you don't want to see any projections, you don't want to see any bleeding, and you certainly don't want to see any crusting and things like that. So, again, please go to your dermatologist.
I have a question to jump in real quick, if you don't mind.
Yeah, not at
I
all.
think a lot of times too, if I may say, people assume that you have to be out in the sun to have had skin cancer. Like there's people that I know that have said, well, I don't live near the beach, so I would never get skin cancer. And that's the fixation that people have. Not fixation, it's the, what's the word I'm looking for?
The mindset. It's just like,
mindset.
yeah.
You think that if you live in that type of environment, you're going to get cancer.
Yeah, there are melanomas for sure that are not related to sun exposure. Some of the other ones that we'll be talking about are directly related to sun exposure. And I know Talaya wants, me to tell everybody about sunscreen. Sunscreen. Am I allowed to talk about sunscreen?
You're allowed to talk about whatever. I just want to make sure that they can digest the information.
Yeah, no, I love it. So
Go ahead.
listen, here's what you got to do. So when Achilles, the Greek half god, demigod, was born, his mother was a goddess, wanted to protect him. So she took him by the heel and she dipped him in this water of perfection, this water of protection. And that was supposed to make him immortal. There's only one problem. She forgot to dump him in that area where she was holding the heel. So when she brought Achilles out, he had one spot that was not protected. And of course, in the Trojan War, what spot got hit? And that was his heel. And that's why you call it an Achilles heel. So I literally want you guys to take your kids, take them by the heel, dip them in 100 sunscreen, bring them out, make sure you don't drown them, and then also put some sunscreen on that spot that you were holding, so there are no possible spots of getting sun damaged skin. Because number one, you don't want to have sun damaged skin because you're going to look terrible. And number two is that you don't want to, risk the development of the second type of skin cancers.
When someone is diagnosed with melanoma, what role, if any, does radiation play in the treatment plan? Because when we think of radiation, it's really targeted. When I had radiation, it was in specific areas. Everything had to be lined up just perfectly. How does that work with melanoma or skin cancer? Because it could be all over, as you said.
Yeah, great question. So my role in melanoma is much different than it is in bladder cancer. So melanoma, and here's the great news, all the new stuff that we were alluding to. So the immunotherapy, the targeted therapy, that's the stuff, that's the juice that's going to save you. That is going to be the stuff that if you respond, that's going to take the worst experience of your life and it's going to make it into the best experience of your life because you can do well even with an advanced melanoma. The role of radiation therapy in melanoma is very restricted, to your point. The woman that I just saw the other day, I'm going to be treating her brain because she has spots in her brain that I have to treat, but she's responding very well to treatment, and I expect a lot of her, all these masses, as I said, throughout her body to disappear. And my role would be just control the brain. We're going to do that with a new modality called stereotactic radiosurgery, which is a completely separate podcast, which we can talk about, but it's very, very focused, small spots of radiation with high, dose to very small regions to protect the brain so you don't get what's called the fancy word neurocognitive dysfunction. If you have a melanoma that has sadly spread to a bone and it's painful, radiation to that specific bone may be helpful. The fancy word in this case would be for palliation. So maybe not for cure, but to improve quality of life. The woman we spoke with, I'm going to speak to her oncologist, her melanoma specialist at Memorial, and discuss the potential use of radiation because she's got all of these lymph nodes that are affected with the melanoma near her stomach, and it's pushing on her stomach and causing great pain, and she's not able to really eat or be able to take in nutrition. So I'm going to propose maybe giving 5 days of radiation just to that group of lymph nodes as we're waiting for the immunotherapy and targeted therapy to work. So spot treating things for symptoms to control the brain metastasis, bone metastasis, or maybe visceral metastasis.
Thank you, Dr. E, for going into detail about that. I think it's so important for people to just understand some things that they can expect or what their options could be. So thank you. And if you are ready, we can
I'm not ready.
into...
No.
Okay. All right, we'll wait.
No.
Yeah,
This is actually this
Mhm.
is actually the pleasure of today's discussion because basal cell and squamous cell skin cancers are extraordinarily curable, and there's no reason why they're not. So this is the sunscreen part. So many of my patients who don't have that protective, I have olive oil skin, with deep coloring, and Talaya, you have this beautiful chocolate skin, which is protective. But some of our patients that have very fair skin don't have those protective mechanisms. And if they have been sun worshipers, so I'm old enough to remember being like having myself like putting on baby oil to cook myself in the sun, to look cooler, to look more tan and look more attractive or whatever. That was a thing. So instead of sunscreen, you're actually putting on oil to burn yourself, almost like if there was a frying pan, you would basically be a fried egg out in the sun just to look pretty. And people like that are now suffering. People with fair skin, we call them basal forms because they are getting all of these basal cell carcinomas. I have people that I've treated over 30 sites for their basal cell carcinomas or whatever. So these are curable skin cancers, but guess what? You need a dermatologist. You have to see them because as we get older and our sun damaged skin, you will be able to tell the difference between what's a solar keratosis, what's just a big skin tag, and what's a skin cancer. Basal cells look very pearly. They almost look like small, like little zits, may be discolored, may bleed. They may be nodular. There's all sorts of different types. These are less aggressive than the squamous cell carcinomas. Again, melanoma skin cancer, non-melanoma skin cancer is usually squamous cell and basal cell. There are others. There are more aggressive others. There's Merkel cell and all sorts of different types. But let's just stick to the most common is the squamous cell and the basal cell. I do have a pet peeve. We're going to talk a little bit about surgery versus radiation. So in general, if you have a non-melanoma skin cancer that's in a very accessible area, so let's just say a cheek or a forehead or something like that, the dermatologic surgeon will come in and they'll either do a shave biopsy and just kind of take it off. They'll do a punch biopsy, or they might do something more aggressive, which is called Mohs surgery, Mohs. So Mohs surgery is where the surgeon has to be very gifted and very talented and very experienced because what they do is take out everything they could see. So the patient is still in the chair and they send this tissue to the pathologist. The pathologist will fix that tissue right there, right while the patient is there, and they'll look at it under the microscope and see if all the margins have been cleared. And usually the surgery goes on and on and on until everything is clear and there's no more cancer. There's only one problem. That leaves a big hole in the patient. And what happens is this wound has to heal, not by primary intention where you sew it up, but it just has to kind of close on its own. So for several months, you might have a big disfiguring wound, and that's okay. That's appropriate for certain types of skin cancer. I think that radiation therapy using what's called an electron beam. So that means that just we're shooting small electrons from our machine at these skin cancers is equally effective as having to have this big disfiguring surgery. However, it only is appropriate in certain places. So if it's in an area where the surgeon feels that the cosmetic effect might not work, may not look good. So over by the nose, the nasolabial fold, by the side of the mouth, over by the lip, we call that the vermilion border, maybe in an area, by the eye near the periorbital area. In these cases, radiation therapy is actually a better modality for you. Squamous cell is a different character. Squamous cell, you have to look for lymph nodes and you have to do a CAT scan and you have to make sure, because I have seen squamous cell skin cancers kill, more people than I'd care to remember. And I don't want anyone to take squamous cell as, oh my God, thank God it's not a melanoma. A squamous cell can be something that could be very dangerous. So make sure you get that taken care of. Sometimes radiation therapy is used in what we call the adjuvant role. So you can do the surgery where the surgeon takes out the tumor and then maybe does a neck dissection or a lymph node dissection. And then if there are bad prognosticators, meaning bad factor that we look at, like metastatic lymph nodes or whatever, then radiation therapy afterwards might be appropriate to try to prevent this cancer from coming back. And my take-home message, where I want you guys to really take this to heart, is that I still, in 2025, see patients with what I call, and this is the scientific word that was used in papers back in the 1950s, 1940s. They used to call these horrifying basal cell carcinomas. That was the word, because there were recluses and patients that would not go to doctors that would have the half of their head covered in a skin cancer. And I know that you would say, wow, how could that possibly happen? How could a person live with this big bleeding, grotesque and malodorous, how long did it take for this to get this way? It looks like they have a crater. Guess what? It still happens. I saw someone last week with a 10-centimeter hand squamous cell that was on their hand for about 5 years. And then last Friday, so just 3 days ago, I saw a woman whose entire eye has been pushed all the way to the cheek with this big skin cancer. So I would like to absolutely implore everyone out there, you don't have to feel alone. You don't have to feel embarrassed. You don't have to feel that you have to hide anything from either your friends or your family or from yourself. Please do not go into denial. Please go to your skin doctor. If you happen to be one of those patients, and obviously there's mental health issues that could be involved in these kind of cases, but if you do get to a radiation oncologist, again, have no fear, because I feel very confident that the woman with the hand cancer and the woman with this, this mass that took away her eye, I still think that we'll be able to make a huge difference in their life. Maybe we won't be able to get rid of all of it, but I bet you we can get to a point where their cancer is in a remission, or it's stable, or it's not growing and it has reduced, and they could actually go out in public without a big dressing on their head, or they can go out into public and participate in life again. And I just want to make sure that that there's always hope.
Thank you so much, Dr. E, for going into detail about melanoma and the different skin cancers. You've made so many great points. A lot of people can just think that a mole is just a mole, and it could be, but just having an idea of what to look for. You mentioned crusting, bleeding, oozing, those kinds of things, discoloration. Those are things to keep an eye out for. And as Dr. E said, make sure you have a good dermatologist and go get your whole body checked at least once a year. And sunscreen, sunscreen, sunscreen. Even on a cloudy, overcast day, you can't go wrong with sunscreen. Dr. E and Angel, as we wrap up here, do you have anything else you would like to share? Any additional words of encouragement that you would like to share with the Navigating Cancer Together community?
Angel, I'm going to leave as I always do. I always leave you with the last word.
I think the thing that we got out of this today, at least for myself, is coming together. It's learning to communicate. It's not allowing fear to dictate our future. It's putting, whether it's your faith, whether it's your knowledge, whether it's your comfort zone with your doctor and your family to overcome whatever obstacle, diagnosis, whatever triumph, whatever situation that comes up in your life. It's not always a bad thing. But as we know at best, sometimes what we assume is bad turns out to be amazing.
Thank you, Angel. That was beautiful.
Dr. E, any last words that you'd like to leave us with?
Talaya, I just think the work that you're doing is so incredibly important. And I just want to tell you, I'm so looking forward to working together more closely. I can't wait to continue to do joint ventures with you. I just wanted to say thank you for being here. Thank you for being a cancer doula. Thank you for letting us learn about what a cancer doula does. Thank you for, having your navigating cancer life. I mean, this is not your job. This is your life. This is your passion. This is what you've lived. You're an advocate. You're going to help so many people that you didn't have a doula to help you walk through. Getting that call in the car on a Friday night that you have cancer and having to pull off, a freeway and walk into an Annie Says or where you were, to just kind of get your legs under you just to be able to go home. And those things can't happen. I will leave you all with a story because, I appreciate giving me the opportunity to talk about bladder cancer and skin cancer for this month, this very, very worthy, platform to talk about these things. But I want to just get into the ears of the doctors and the nurses that are taking care of you all. And I want to leave you with a story. And I call it the Lollipop story. So most of what I do on the Croc Podcast really comes from real life. These are real stories from real people. And these stories are what teach me every day on how I want to be and how I can be better. And I think that I want it also to trickle down to all of my colleagues to make them better. And some of the things that we do that we can't do anymore that we need to avoid. So there was this lovely, lovely woman that we'll call Cynthia, a young woman who probably about 3 months ago started having difficulty to swallow and to eat and started having a pain, in her mouth and in her tongue. And then she started having some bleeding and thought that she bit her tongue and then felt a lump in her neck and thought maybe she had some kind of a cold or a sinus infection. And she went to go to her primary care, who looked at her tongue and saw this big tumor and felt her neck and found this big lymph node and referred her to an ENT doctor. An ENT doctor is a head and neck doctor who specializes in the ears, the nose, and the throat. And this ENT doctor was an older practitioner who not such good bedside manners, put the patient in the chair and was very, very curt with them and examined them and was just doing this, shaking their head, doing that whole, oh no, this is not good. This is not good. Shoving their hands down the throat, taking a big needle and just punching it into the tumor to get a biopsy. And then after the patient was putting themselves back together, the doctor came in and said, this is not good. I know you have cancer and you're going to die from this cancer. And the patient lost it, absolutely lost it, started crying uncontrollably. And what the doctor did was, instead of going there and just trying to lift the person up, lift this human being that they had beaten to the ground and try to help them navigate, tell them what comes next, give them a task on who they need to see, how they're going to help them take care of this problem. But instead of doing that and holding their hand or hugging them or wiping away their tears, she said, excuse me, went out into the waiting room and came back with a lollipop and gave the patient a lollipop. And when the patient was telling me the story, she went into her purse and she pulled out that lollipop to show me. She carries that lollipop with her everywhere she goes as a reminder of the brutality of what she went through. So now she's in our center and she's being nourished and loved and taken care of. And we have everyone descending on her, from the nutritionist to the speech therapist to the psychologist, to the pain clinic, you name it. We have her plugged in. And you want to know the best thing? She's not going to die from this cancer. So in ending of today's podcast, I want you all out there to know if you're taking care of survivor thrivers, you have an obligation. You have an obligation to not render them incapacitated with fear and with hopelessness, but to do the opposite. No matter what it is, whether it's someone who comes in with a skin cancer that has taken their eye away, or a big breast cancer with a big hole in their chest, or a big cervical cancer or anal cancer, whatever, it's our job not to show the cards. It's our job to try to help them navigate through that river, that torrent of water and danger that they're going through. So please do not, and this is a metaphor, please don't hand any survivor a lollipop. Give them a part of yourself.
Thank you so much, Dr. E, for sharing that story and the importance of truly caring about the patients that you're serving. I think that story is so important. And Angel, thank you so much for joining us as well. Thank you for sharing your faith and your positive affirmations here on the show. Again, I just want to remind everyone, please make sure to listen to Have Faith, Let It Begin, as well as the CROC Podcast. And you can find those two podcasts on all of the major podcast platforms out there. You can also just Google it, and I'm sure it will come up as well. And I will also have that information in the show notes so that you can readily access those podcasts. Dr. E, thank you so much for sharing your knowledge, wisdom, and setting the gold standard in patient care. If anyone is interested in learning more about CROC and the work that you all are doing, where can they find you?
Oh, this is the best part. So we can be found anywhere on Twitter. You can be found on YouTube, anywhere on social media. You write to us, and guess what? You'll hear right back from Dr. E himself.
Talaya, you're the greatest, and thank you so much for having us.
You are the greatest as well. Thank you, Angel and Dr. East, for joining us today. Before we close out, I have to give a shout out to the Navigating Cancer Together community and valued listeners. Thank you so much for joining us. I hope that you have found this episode very informative as much as I have. That is it for this Wednesday. Until next time, let's keep navigating cancer together. Take care.